Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Alexandria Wynter Russell is the owner of a private practice. She receives compensation for her participation in this podcast from SpeechTherapyPD.com. Her non-financial disclosure is that she is a board member of the Parkinson's Council and a member of ASHA and the Lingraphica certification program. Her father has Parkinson's and dementia. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms and other webinars on SpeechTherapyPD.com, I do receive financial compensation. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Alexandria Wynter Russell, MS, CCC, SLP, who is a medical speech-language pathologist and private practice owner of the Wynter Wellness Group. She is proud to be the only Black, woman-owned SLP practice in Philadelphia that solely serves the adults and senior population. Her journey as a caregiver to her dad with Parkinson's, specifically helping her parents navigate the healthcare system through COVID-19, inspired her to begin her private practice. Her practice centers around 5 central values: advocacy, health literacy, nutrition, mental health, and community. Celebrating her work in the Philadelphia community, Alex was recently featured in the Lingraphica documentary, Witnessing Their Words, and recently named an ASHA Innovator. As a healthcare provider, caregiver, and entrepreneur, her mission is to help you become a confident advocate and find your version of balance. Welcome, Alex. It's so great to see you.
Hi, Renee. Thank you so much for having me. I'm excited to be here with you today.
Oh, of course. It's always interesting when I host the podcast to hear kind of how people got started in the SLP field and how many of us have these really personal connections to the field that, like, I grew up not even knowing what a speech language pathologist was, and my exposure was at the age of 25 when my dad had a stroke with resulting aphasia. So it's always interesting, I think, to make that connection and hear the personal stories, because professionally, I think it gives us a totally different perspective having been on the caregiver side of things. And so, we're talking tonight about, working with this adult population and how to build an effective treatment plan. So let's start out with talking about some ways, because this is one of my favorite things to discuss with other professionals, especially at work. What are some ways to build rapport with patients?
That's such a good question. And I I feel like it's so important to have that rapport. You may be even thinking, like, why does it matter for my patient to really like me or to want to come to therapy, or why do I need to spend time building this relationship, right? I'm the therapist. I'm going to go in there, I'm going to evaluate, we're going to have a treatment plan, we're going to do therapy, and that's it. But I think when we miss that rapport building piece, we miss that huge opportunity to actually create a person centered treatment plan. We miss that opportunity to know what is even going to be functional for our patient. And we get to learn more about them, right? It allows for more communication, it builds trust within the therapy environment. And I have found when I spend more time letting my patients talk to me, letting them share with me, learning more about their stories, why they have been upset with other therapists in the past, or why they don't even like speech therapy, right? Like, who wants to sit there and say, hey, I'm your speech therapist, but please tell me all the reasons why you don't like speech therapy, right? But I always ask that question because it it gives you so much important information. It helps you to start on a really great foot. You know, if you can go in there and know, not, I'm not going to say every single thing because it's still a growing relationship and you're going to learn more every session. But if you can start out your session knowing like 3 activities that absolutely drives your patient like bonkers and they don't want to do, like, wouldn't you want to know that before trying to do all 3 of those things and subsequently making them very upset at you without even knowing?
Yeah, no, I agree because two of the things I always say is I think worksheets have a place in home exercise practice and maybe in sometimes in the treatment room, but I think sometimes people get reliant on that. And a lot of times that's what I hear from my patients, particularly when I was working in outpatient was I had that one lady when I was in the hospital and all she did was give me a pack of worksheets and I
Yes.
never did crossword puzzles before. I've never been good at XYZ and I've heard that so many times. But the other part of that is, we tend to be particularly when in the cases of like outpatient therapy, I think private practice more so in inpatient rehab, we tend to be more one-on-one and sort of this secluded, not secluded is probably not the best word, but we're in a space where there's not a ton of other people, right? We're not always in the middle of the gym with 10 other patients and 10 other therapists. And we sort of build, like you mentioned, that trust, but there's a level of intimacy where the patients feel like they're in a safe space, they're one-on-one, or maybe they're one-on-one with us, and maybe there's a caregiver or a student in the same space. But they tend to come in and tell us things that they don't always tell the other medical professionals about their sessions, about their interaction with the weekend staff or the night staff or whoever it was, or if they, and sometimes it's not always negative, sometimes it's really positive things that they just still don't feel comfortable telling that other person that they interacted with. And so I agree with you. I think it's really important on that level, but definitely that person shared experience and being able to really customize their treatment for what their needs are. Because what 94-year-old long-term care great great grandma needs is not going to be the same thing that 45-year-old still working mom of 3 needs. So I think
Yeah.
that it's all like great points to keep in mind because it's not a one size fits all.
It isn't, and I wish I knew that earlier. Like, people always ask, like, "Oh, what's one thing you knew, like, in grad school or one thing you knew as a growing clinician?" You know, I remember my first position as a CF working in a SNF with hundreds of beds and floors and patients, and I I mean, I knew what I knew from school. I had never had this real life experience. So I was doing the same activity with every patient because I was scared. I had to stick to my structure, and I didn't know what the 94-year-old liked to eat for breakfast and what her son's name was, nor did I know the 45-year-old. I was just head down, blinders up, and going in. And I think if you find yourself in that position, it's okay, you know, because you don't know what you don't know. But I think also take this opportunity to say, whoa, like there's a whole nother side here to therapy that can really help me. And I think for me, coming from that kind of scared, nervous student perspective, it seems kind of daunting or scary to like talk to this person who's had a major illness or a major injury, and now I'm asking them these personal questions. But I have found, and I would be curious if you agree too, Renee, that most people love to talk about themselves. And like you said,
Mhm.
oftentimes they're not getting that chance, right? Doctor's visits are in and out. Maybe PT was just focused really on their walking and they didn't have chance for a lot of conversation because they were focused on giving them safety cues. And, the aide was focused on washing them and asking if they were in pain. And so maybe by the time we get in there for speech therapy, they're ready to talk. And so I think we have to be ready for that opportunity. And it I'm going to give you some of my favorite questions because I think it's so, so simple. A very simple way to build rapport is just asking people questions. Do you have any questions about today's session? Did you have any
Mhm.
concerns? Right? Is there anything specific you want to focus on? Do you need me to send your note to a note to your doctor about anything? Should we come up with a list of things you want to tell your physical therapist? Like just getting to know them in the whole sense of who they are as a patient and how they're interacting in their everyday like rehab healthcare life, and then in their personal life is going to help you help them.
Yeah, no, I agree because early in my career, I worked mostly with TBI patients and stroke patients and some other neurological diseases sprinkled in there. But I was always, I always say this, it sounds so, I think to people who work in our field, they understand it. And to other people, they're like, what? I love a good TBI. I'm weird like that. Like, that's my favorite thing in the whole world. And so that was like my jam. That was who I wanted to see. That was who I wanted to really help develop that treatment plan. And so one of the things early on, and this has actually happened when I was a student, I was doing a pretty intense thesis project, like an in-person sole subject patient with aphasia who was a couple years out from her stroke. And she had a teenage son, but she was a single mom. Her husband left when she had the stroke, and she was trying to go up to school. There was a lot of scenarios that she would come in and try to share as best she could with her Broca's aphasia. But one of the things that happened to her was going to school to talk to the guidance counselor about her son because he was about to graduate. And the school secretary thought she was drunk because of the aphasia. So she came in
Mm,
and she had some writing ability. So anyway, she was telling me this story, and it just, for whatever reason, for whatever point I was in grad school, because everybody, that was, oh gosh, it was so stressful and emotional. It's like you cry if somebody blinks at you wrong. But that was the first time, and I was a second career graduate student. So I was not a 20-year-old or 22-year-old. I was 35.
right.
And I cried with the patient. And I remember just afterwards getting kind of like, not in trouble, but like, you can't do that. You have to maintain this level of professionalism. But at the same time, sometimes these things that our patients tell us are really heavy and really hard. And I think if you're an empathetic soul, it's hard not to share in that emotion that they're having. And again, I think that is a trust builder because they see,
Sure.
oh my gosh, this really impacted her day and it really impacted how she treated me. And it's an opportunity sometimes when people, especially in a trauma informed setting, for them to get an apology that they may need that may not come from the person that enacted whatever was the thing that upset them, but it's helpful to get that apology from someone who is able to let them know that they care. So I think that's another piece that's really important for us to be human. It's okay to
Yes.
be human with their patients.
Yes. It
Yeah.
definitely is. Definitely. I remember seeing I like to, network in SLP like Facebook groups. I'm sure you're a part of some, right? And I see sometimes people ask like, "Oh my gosh, my patient asked me a question about this and like I don't know what to say, or is that too personal, or I don't know what to share, or my patient wants to share this with me and I think that's too personal." And I think obviously we all, you have to have boundaries, but like you're saying, it's okay to be human. It is okay to share things that you like to do, and places you've been, and things that are you feel especially can make an impact in your patient's life or that they can relate to, and even that is going to allow them to feel comfortable talking to you, even yourself, think of the past experiences you've had with healthcare providers or even teachers or anyone that's in, kind of that teacher student relationship. Like, when have you felt the most comfortable and willing to share? And I'm sure it's when you felt like it was a real person who was talking to
Right.
you and working with you.
Yeah, in a safe space. And I think one of the best
Hmm.
things as SLPs we can do for CEUs too is take a counseling course that's geared towards our field. It doesn't have to be, you're not going to maybe go be a social worker tomorrow. Maybe you will. Maybe that's something that you feel compelled to do. But there's definitely counseling for SLP courses out there that help aid in the education that we provide and the support that we provide our patients. Because a lot of times, especially if you work in acute care, it's well, and I think too, people that work with kids, there's a lot of stuff, a lot of extra
Right.
stuff that we don't see and we don't have knowledge of. But kind of jumping off of that, there's a lot of assessments out nowadays, and a lot of, we still are sort of forced into this formal assessment model from insurance companies and reimbursement standpoints. And I think some assessments are better than others, and I won't put my opinions on those. But what are some of those cognitive and swallowing and communication assessments that you find yourself using with adult patients?
I am a big fan of trying to use a combination of the standardized assessments with a patient reported outcome. Because, like you said, I find that a lot of the standardized ones don't really capture what is truly going on with that patient. And I primarily worked in an underserved community, and just a lot of the, test
Okay.
stimuli and even the timing requirements just aren't really feasible, right? But insurance is asking for specific things. So you do have to do that on occasion, but I feel like adding that patient reported outcome piece is so, so important. Okay, but so to name a few, I really like the cognitive communication checklist for acquired brain injury. A newer one I've been using as the Lawton instrumental activities of daily living scale. It's super easy. It's really just a way to get a good look of how independent this person is in their environment and what ADLs they're needing varied levels of assistance with, which can give you a good idea of how they're going to function with their cognition and communication in those situations. The communication confidence rating scale for aphasia,
Mhm.
the voice handicap index. I think I use that one about once a week. The multifactorial memory questionnaire is also like a favorite of mine. If I had this like when I started school, I would be waving it from a flag from the rooftops. This is absolutely one of my favorite ones because I feel like when you have those patients who are telling you, "Oh, I'm fine, but like sometimes I struggle with this, or sometimes my memory is just a little bit off," and they're telling you something's going on, but you can't quite figure it out, and like the standardized assessment isn't capturing it, and then you give them the multifactorial memory questionnaire, and it goes through all these daily scenarios. I love that. Really talks about the gaps in their memory throughout their every day that seems to be, impacting how they're functioning. So it's like forgetting to pay the bills, forgetting your glasses, forgetting words in conversation. It also goes over the kind of emotional piece of memory loss. Like it asks how the person is feeling about their memory, which is always a great question to ask in general, right? To your patients, how are you feeling about your voice impairment? How are you feeling about your swallowing impairment, right? How do you feel about your aphasia? Let's see what else. The EAT 10, that's a classic
Mhm.
one. The brief cognitive assessment tool, the short form, the Western aphasia battery, but I also give the shorter version of that, the bedside form, because I don't have the time to give the full one.
Who
Um,
does in a 40-minute, 45-minute session in an outpatient that's normed on a hour to hour and a half for Western aphasia? And that's if your
yeah,
patient isn't delayed in their response time, which we know most patients with aphasia will be. So yeah, what a
wild.
challenge.
It's
Um,
such a huge challenge.
we had two people ask about lists of the assessments you just named. Do you mind going back and I'll type them while you say them? I put E10 for
Oh,
disclosure,
sure.
then
Okay,
I'll do voice.
so yeah, the cognitive communication checklist for acquired brain injury. And almost all of these are free. So if you type them in Google, you will be able to find a PDF of them. The Lawton, that's Lawton, the Lawton Instrumental Activities of Daily Living Scale, the Communication Confidence Rating Scale, or we have the Voice Handicap Index in there, and the multifactorial memory questionnaire, and then the BCAT, the Brief Cognitive Assessment Tool. Yeah, short form.
Multifactorial memory scale.
Memory questionnaire.
Okay, I knew I was getting that wrong.
It's a
And I've
mouthful,
used
that
it,
one.
so that's what I'm trying to read it and write it at the same time. And you said the BCAT short version?
Yes. Yes.
Okay, I think I got them all.
Yep.
Thank you. Thank you. Yeah, I really I use the Beat 10 a lot and the VHI just because they're so quick. And a lot of times what happens is, even if it's not just a voice patient, sometimes if I'm just doing more of a comprehensive assessment where some of the stuff that I got maybe didn't make a whole lot of sense and the patient isn't able to tell me everything, sometimes I'll do the VHI just as part of my dysphagia assessment too, because sometimes that gives us some information, like you mentioned, about how they're feeling. And sometimes too, if they have family, the family will often chime in, particularly the spouse or significant other, and well, that's not what happened yesterday.
Right.
But one of the things I like that you said too, some of the standardized testing that we have in the health systems are not always standardized on the population we're seeing or evaluating, particularly for our Parkinson's patients. So we can give them, the Frenchy dysarthria, but that may not necessarily tell us what we need to know, because that type of dysarthria is different and nuanced compared to, spastic or flaccid dysarthria that's really more geared towards looking at speech intelligibility versus things like breathiness and that kind of pause when initiation of speech and some of those other features. So I'm glad that you brought that up, because I think it's really, really crucial for us to realize that if we're going to look at a particular disorder, that it's helpful to have an assessment that is normed on that population. And again, like you mentioned, a lot of these are free, and you can actually Google assessments for Parkinson's patients too. And a lot of times it'll pop some of those up. And looking at the Lawton, how much, how much of the time would you say that gives you the information too, if it's a patient maybe who is only seeing speech, that helps you be able to make that referral to PT or OT?
Oh my gosh, for sure. That is why I love these sort of like the patient-reported outcomes, because you get to get this holistic view of how this patient is performing in their entire environment, and that's going to include things like shopping and cooking, and you may find out they're forgetting to turn the stove off, or they are forgetting the steps to make their morning coffee. But then you also realize they're having a hard time grabbing their spoon, or they're having a hard time stirring their coffee or getting the spoon to their mouth, right? So it's such a unique opportunity to find out who your patient is and what is important to them to function as safely as possible and as independently as possible in an environment that makes sense to them, right? And is where they are. So yeah, the Lawton is actually a newer assessment that I've been giving. I like recently found it within the last year, actually. And I was like, wow, this is really great, because it's also something I feel like when the patient is telling you one thing, and like you said, the caregiver is telling you another, and you can really bring it together, like with this all right, let's all sit down together. Like, let's actually take a look at this, because you're telling me you do this by yourself, but they're telling me that, you're falling every time you do it, or you're forgetting every time you do it. So let's look at this task together.
Yeah, because a lot of times, I know when I was in acute care, I'd get from the physician, I gave the patient the mocha, or I gave the patient the slums, and they couldn't remember the 3 words after 10 minutes. And I'm like, I probably wouldn't either. Or
Right.
the
Like
count backwards by serial sevens. And I've had PTs tell me that too. And I'm not picking on any discipline by saying this. It's just, this is the referral that I would get. And I'd be like, Honestly, I don't think I could count backwards by sevens. I'm going to tell you right now, I
Yes.
feel like I'm pretty intelligent, and I'm not going to be able to do that. I can get to like 93, and then after that, I'd have to sit there for a second. So if you want to call me delayed, I'm not a mathologist for a reason.
Hmm.
So some of that, again, what's the relevance to daily life? And I know I saw
Right.
something recently where someone, and it was an SLP, I think, that was working with an OT, and they did a course on the clock drawing. And I have historically not enjoyed that, because to me, say we had someone who are, I think, mid-20s, even up to maybe mid-30s, depending on where they were in school. I don't know that that's relevant. They had
Yep.
digital clocks their entire life. I don't even, probably a little bit older than that. I don't know how successful someone at that age would be. Just like when you give tests that ask, and I don't want to call this test out because it's not a bad test. It's just, I think it needs to be updated. But there's a test with a selected subtest that says what major economic disaster happened in the 1930s. And if I ask someone under 35 that, a lot of times they don't know. My TBI patients under that age don't know. They look at me
Yep.
like, what the heck are you talking about? I have no idea. And it isn't because they're impaired, it's because they really don't know. So I think we have some really great things out there now that, again, I'm with you. If I'd had that when I was a grad student or even in my CF, it would have made my life so much easier, because I constantly felt like I was recreating the wheel trying to figure out, okay, well, they just got 10 out of 10, but I know they can't, if I let them go free right now in their wheelchair, they're never going to find their room, and it's a straight shot down the hall.
Right, right.
Are you taking advantage of our new amazing feature? The certificate tracker. The free CE tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah. And so how do you really incorporate that to work on creating goals for
Mhm.
those patients?
I think one of the most important things is first starting with that rapport building piece. Like you have to know your patient. You have to know the environment that they're going to be communicating in or eating in or working in or living in, whatever that's going to look like. And that way you'll be able to actually incorporate those daily activities that relate to their life. And you can create specific strategies that actually relate to that everyday activity, right? So, I mean, we were talking about the serial subtraction for sevens, right? And if we're going off of that model of, well, I'm going to deliver a treatment plan based off of solely the results of this assessment, you may work on serial sevens to the cows come home with your patient and they may never get it right. And here you are still saying, well, this, you're wrong, this is wrong, you have a cognitive impairment, but how is that related to their everyday, right? Like what from that task can we take away, if at all, if it's important for them, that they need to be able to do in their everyday life, right? Do they need to be able to do some sort of like a mental manipulation or task switching or attention tasks in their mind, right? Maybe they don't. And maybe that task isn't important to them at all, right? Or you can just even ask them, how are you with math? What's your
Mhm.
highest level of education first, right? Because that will also give you a lot of information about their literacy, but also their health literacy. So we really have to get to know our patients. So I think incorporating those daily routines and that contextualized practice, right? I always think the goal should be to improve something in real life, like a functional activity. And then therapy is going to work on developing, rehabbing, maintaining, restoring, depending on that patient, what that looks like for them, right? But helping all the different components that make up that skill so they can be able to do that task correctly. So that's what I love. So maybe, instead of we're just working on math sheets of just kind of random addition, subtraction, multiplication tasks, which are, yes, important, but what's the end goal here, right? Is maybe to go to Wawa, or that's a Philly thing. So maybe whatever, 7-Eleven,
We
or
have that here.
whatever your
That's fine.
your local store is, right? To be able to go to the store, buy their morning coffee, and like make their change correctly. That's the end.
Mhm.
That's the end goal. So I think always having that end goal in mind, what is going to be functional for this patient? Is this something that they even want to do, or is this something, again, that I just made up because this assessment told me mark them incorrectly on it, right? And what's also realistic, I think, is the important thing to ask yourself. Like, how much time do you have with that patient? Are you setting goals too high? I know that was a big thing for myself starting out. Like, I was setting goals like patient will complete, this task with 100% accuracy independently. Like, that is a really, really high level like, even think of yourself. How many things you do every day, and do you do it 100% accurate? Right, without any sort of cueing, without looking at your phone, without an alarm, without. So it's a really, really reaching for the stars type of goal if I'm going to be using 100% accuracy independently. So I think reframing how you think about setting goals. It's okay for your patient to
Mhm.
do things with assistance. It's okay for them to build up to 50, 60, 70, 80%, 90, whatever that goal is, or whatever you're working on. But I think being realistic and looking at your time and how much assistance that person has, like, all of that's really going to help you set a really targeted and functional goal.
Yeah, and I think one of the things I learned early on, and it was because I was in inpatient rehab and we had a team of SLPs, and I was the newest, and or at the time that I got hired, I was the newest. And so one of the things that they had started to do and we sort of compounded on was doing our own assessment. And what we would do is call it selected subtests of the WOB and the
Mm,
ABCD and the BCAT and some other tests that we found. These sections were really good and strong and could really generalize across aphasia, but also cognitive communication disorders. But we had these biographical questions on there, like, what's the highest level of education you completed? What was your occupation, or what is your occupation? What hand do you write with? And then looking at medication management and
mm,
financial management, because for some people, they never manage their own meds or their finances. Or one of my favorite patients, and she wound up really not even being my patient. One of the favorite referrals I ever got in acute care was this lady who was 85, super super with it. Like, I mean, she was on it. She was not in the hospital for anything related to swallowing, nothing neurological. I think she had like, I don't even remember. It was not anything. It was a general medical problem that would have not been an SLP consult. And I wound up
mhm,
getting a swallowing consult on her because she put her pills in applesauce to take her pills. Well, she'd had esophageal stricture in the past with dilation that was successful. And when she finished with that treatment that was like 20 years ago, she said, I've always since that time taken my pills in applesauce because it doesn't cause me any distress. And so I've been
mhm.
doing this for 20 years. And I was like, well, what would you like to change? And she's like, I don't even know why you're here. I'm not changing anything. I'm 85 years old.
Right.
And I thought that was like the funniest thing ever. And she was adorable. And I would have loved to work with her, but we literally had nothing to do because she really liked taking her pills in applesauce. The end. It was the end,
Yeah,
But I think, again, it's an important question to ask. What would you like to see come out of us working together?
yep,
Because in the case that the patient maybe is impaired, and we're looking more at quality of life in the case of, our head and neck cancer patients, or our patients that are more end of the stages of Parkinson's or ALS or something like that, sometimes they opt to not participate, which is fine, which it's
mhm,
fine, because if they are educated on what the risks are, if they're having issues with their swallowing or even issues with their memory, but they have assistance and they have a system, then who am I to come in and change if they don't want to change and they just want to go live with the time that
yeah,
they have left? And so that's another, I think, really important consideration when you're building rapport, is to ask that question. What would you like to see come out of us working together? Is this something that you think would be successful? And then back to the math, it's kind of funny because I had someone in outpatient a couple years ago, and he would say, "Well, I've always done the bills," and he'd look at his wife, and she's sitting there like she's invisible, and he goes, "She doesn't have any idea what she's doing with the money." And she'd be over there rolling her eyes. And so we worked on some really simple functional math, like you went to the store and a bag of chips is $1 and a soda, of course, these are old prices, $2.79. Will $5 be enough? If $5 is enough and you pay, how much would your change be? That kind of stuff. And
Mhm.
he thought it was so funny because he was like, "Oh, I'm going to ace this," and he got like the first three wrong, and he was like, "Oh, we really need to work on this math."
Yeah.
It's so sometimes just doing that little activity is not really part of your assessment, but it's, sort of like your diagnostic therapy on session 2 or 3 kinda opens the
Yes.
patient's eyes to that maybe I could do this a year ago and maybe now I'm, a little struggly with it.
Yeah, and I'm glad you said, like, session 2 or 3 because sometimes you can't gather all of this information in your first evaluation, like,
Mhm.
it's okay to still learn more and create those more specific goals as you go along. I think that was another thing that I had to learn was okay to do was I didn't have to create every single goal at once and know like everything about this patient on the first visit. It was okay to add goals to their treatment plan and to also not completely overwhelm the patient with a
Yeah,
million
who
things
needs
that we're going to work
5,
on.
6 goals on day 1? Start with 1 or 2 kinda more general, and then, like you said, you can
Yeah.
customize that as you go. And it doesn't have to be straight from a goal bank, but again, I think when you've been doing it for a little bit, you can look at more like, call it functional memory activities
Hmm.
with 75% accuracy and mod assist, and then you can adjust that or add something a little bit more specific about that patient. Yeah, I think that's helpful too. And then if you are someone who's working on a multidisciplinary team, working with those other teammates too, whether it's acute care, you may be working with a dietitian and you may be working with respiratory therapy, and you can kind of your goals won't be the same, but you could talk to them about, what they're working on and how that kind of crosses over into what we're working on, particularly if you're using like an expiratory muscle strength trainer for your patients who might have some airway compromise, and how, the respiratory therapist might have some insight on that. Or PT, same thing. Do you want the patient sitting up on the edge of the bed, or can we get them in the chair for meals? All those sorts of things that are really super functional.
Hmm.
Most people, I know that there's a lot of talk, and especially in dysphagia, and I'm not BCSS, I'm not a swallowing expert, but I do have 15 years of experience working in hospitals. And there's some difference in positioning and ways that people have been positioned. But I think, you know, when we're working with the PT, a lot of times, and even OT, we want those patients to be as upright and mobile because we know that helps decrease that risk of them lying in bed all day and being at higher risk for development of pneumonia
Hmm.
and things like that, depending on what their other medical comorbidities are. So again, those are functional and seems like it's really simple, but just like our caregivers aren't instinctually knowledgeable about giving the patient who with aphasia extra time and not filling in the blank. People want to help, right? So
Yep.
they jump in and they don't always give the patient the time they need. And the same thing, I think, when we're looking at our treatment plan and trying to make it this, I won't say cookie cutter, but we sort of learn that in school, that cookie cutter come out and you're going to put this in the box and this is what you're going to do, but it doesn't always work,
Yeah.
particularly with our patients with neurological disorders. So let's jump into your favorite question about
Mm.
what is it that you do when your patients maybe didn't have the best experience with speech therapy in the past, or maybe they're not doing their home exercise program, and so they don't think it's working because they maybe can only come 1 time a week, or maybe you can only see them once every other week. So how do you address that when the patient comes in and goes, "This isn't working, that's why I haven't been coming"?
I think the first thing, and I feel like a broken record, but it really is first and foremost that rapport with your patient because if you don't have a good relationship. And when I say good relationship, I don't mean you have to be best friends. Like I don't mean it in the sense of like you and your friend, but at least a relationship where there is respect and trust in a healthcare setting or whatever setting that you work in, right? Because this may be a tough conversation that you have to have with this patient and vice versa. They may tell you things that you may be a little bit shocked to hear or didn't know about them. And so I think after you've established rapport with your patient, we have to ensure that not only the patient, if there is a caregiver involved, or care partner, whoever is that, they know what you do and why you're there. Because speech therapy, still to this day, is a very ambiguous term for many people, especially if you are, I know home health setting the best. I also have sniff experience in outpatient, right? But imagine you're in home health and you are having 5 to 7 different people come in and out of your home 3 to 5 times a week. And you just
Yeah.
got out of the hospital where you were seeing double, triple the amount of those people walking in and out of your room, and you were probably on a lot of medications and you were a little bit drowsy, and let's add a cognitive impairment on top of that, a communication impairment, maybe some sort of physical limitations. Like, it's a lot. So I don't expect that you know 100% everything that I do and why I'm there. In fact, I never assume anymore. I never assume anyone knows what a speech therapist is. I always say, "Hi, my name is Alex. I'm your speech therapist. Have you ever heard of a speech therapist before?" It rolls off my tongue in one breath now, because that is automatically going to let me know if you know really why I'm here, and how many times, I'm sure, Renee, how many times a patient just gets a referral for speech therapy without any sort of like extra information about it. Like they don't know. They know the PT's there to help them walk. They may not be sure why the OT is there because the PT is there to help them walk, and then they really don't know why the speech therapist is there because he talked just fine, right?
Yep.
So I think
Yep.
first, making sure that the family, patient, caregiver, whoever's involved, that they know what you do and why you're there. Because chances are, if they don't, you've also just missed that huge opportunity for them to start that trust building with you. So, explain your scope of practice and
Mhm.
explain, why they're there. I think also it's kind of twofold in knowing this role of the speech therapist. Do they actually understand their medical diagnosis and that relationship to therapy? Because that's also important to know. Well, I have Parkinson's, why would I need a speech therapist?
Mhm.
Or, I have breast cancer, why would I need a speech therapist? But no one told me that, I'm suffering from memory loss from my treatments and that you were going to be the one to help me. Right.
Mhm.
So I think making sure that we're helping our patients with that health literacy piece, because in the end, that's going to help them advocate for themselves and let them know what services they need and what they qualify for. And in addition to the scope of knowing your scope of practice, also, do they know the purpose of the exercises? And this one can like put you in check too, because you're going to have to explain why you picked all of these therapy exercises, these treatment plans, the home exercise plan, and how that relates to some sort of goal for them, right? And
Mhm.
is it a goal, excuse me, that you set, or is it a goal that was collaborative, that the patient and you worked on together, maybe even the caregiver as well? So I think all of those things will help when that patient is saying, well, speech therapy just isn't working, right? Like, go back to kind of those basics. Like, do they know the scope of practice? Do they know their medical diagnosis and how it's related to speech therapy? And do they even know why you're giving them these specific exercises? Do you know why you're giving them these specific exercises? That will also help. And then the home exercise program piece. I mean, this really hit home for me when my dad's journey with Parkinson's, when he advanced through his Parkinson's stages. Because, right, we're getting home health. I'm a home health clinician. I know the ins and outs. I know, quote unquote, what should be done, right? Or what's going to be
Yeah.
optimal, what your nurse and doctor want to see, what the PT and OT want you to be doing at home. Now, my dad doesn't get speech therapy, but in those other disciplines, right? And I can't tell you how many times my mom or my dad, even myself, have not been able to follow through with a home exercise program. And that's not to say that we don't recognize the value. That's not to say that we know it's not important. But I didn't realize that with caregiving comes fatigue and
Yeah.
overwhelm, mental and physical.
Hmm.
And even with patients dealing with a new diagnosis or even a chronic condition they've been dealing with long term, there's fatigue, there's overwhelm. People have other things going on in their lives as well when you leave that house or their apartment or wherever they live, right? There's so many other things going on, relationships, work, money,
Yeah.
all of those things that can be very complex, especially after an illness, or some sort of major life change that's disrupting someone's loved one's health. So I think we have to ask, in terms of a home exercise program that we're giving to our families, what is actually realistic with their schedule? How much time do they really have? Because honestly, it might be 20 minutes. It might be 1 hour twice a week. It may be 5 minutes in the morning and 5 minutes at night. We really have to like get on our patients level, caregivers level, and figure out what a home exercise program looks like to them, because
Hmm.
home exercise program is such a vague term, and it's easy to give that sort of deliver that cookie cutter approach to all of your patients. Here's the workbook of all of these exercises, or here's these 30 repetitions of these 10 exercises you're going to do, and they're never going to look at it because it's just a lot of information, right? So I always say start with 1 to 3, depending on the person. I start with one. I give like
Hmm.
one task for a home exercise program and come back a week later, and we go over it. Like, how did it go? When were you able to complete it? Did you need help from anyone? Did you have enough time? Do you feel like we can add something else for this week, or do you feel like you need to stick with one thing? Just
Right.
having those honest conversations, because yes, they are your patients, but they're also people who are dealing with some pretty tough things at home. And sometimes their home exercise program may not be at the top of mind. So let's figure out how we can help them work it into their lifestyle, because we know it's going to be important for them to improve.
Yeah, and I know that there's a lot with, dosing as far as how much time we expect and how many reps we expect and all that kind of stuff. But I'm with you on that. Sometimes it's not doable. Sometimes it's not feasible. And it's some of the challenges too when we look at social determinants of health. You mentioned a lot of it. A couple things too. Food insecurity is one that I've seen a lot with my patients,
Hmm.
particularly my geriatric patients or the patients who are reliant on Medicaid transport. Transport is another issue
Oh yeah.
where they may not be able to get to outpatient, and maybe they are a home health patient, but then they can't get to their medical appointments because their Medicaid transport person no showed or came late. They get to the doctor's office, now they can't be seen because they're late. And so there's a lot of pieces that I think get lost in translation, and people who haven't been on the caregiving end of it don't always see it in the same light that you do when you've been on the caregiving side of things. Sometimes too, people are just fatigued. They don't feel
Yeah.
like doing it. I know when my dad first came home, and this was many years ago, but when he first came home from acute care, well, he had been in inpatient rehab, but when he did home health, he had all three disciplines and nursing, and it was like he was wiped for the
Yeah.
day. It was just a lot for him, and he was young. He was only 48, so it wasn't like he was geriatric. But a lot of those pieces come into play, but I like some of the parts about, when we're thinking about the education level of our patients or what they don't know about what we do. One of the most helpful tools I had an outpatient was my little model larynx, because I could say your
Mm.
vocal cords have two really important jobs. One is producing voice and the other is protecting your airway when you swallow. And I think you do sort of get these little mantras that you say and these things that sort of roll off your tongue to your patients. And as soon as you say it, they're like, boom, the lights went on, and they're like, oh, that makes so much sense. And show it to me. Visual aids are so helpful. but also having the diagnosis of the communication disorder or the swallowing disorder, because then the patient goes, no one's ever told me that. I knew I had a
Yep.
stroke, but I've never heard that word. I've never heard dysarthria, or I've never heard aphasia. And sometimes they can't say it in a full sentence, but a lot of times the shock and awe on their face of like, holy crap, somebody realized finally that I know what the word is I want to get out. It's just not coming out, or it's leaving me before the motor piece does its job. And so I think those are all really, really super important ways, again, to go back to the original, building rapport, because it's letting the patient be seen in the space that they're in and meeting them where they're at. And that's so incredibly important.
Yeah.
So I don't see anything in the chat right now, but can you give a patient example and sort of walk us through that assessment piece to how you would then use those things that you find out about your patient to help create a treatment plan?
Sure. So I'm thinking of a patient I used to work with that I discharged a while ago, but this was a person in their 80s who had had 3 strokes and diagnosed with a cognitive communicative impairment. This patient has had nothing but negative past experiences with speech therapy. In fact, I went in there, this patient and their partner, well, I will say the partner was very excited about me being there and very adamant that their partner needed speech therapy. But the patient really did not want anything to do with me. In fact, I will say I was getting a little discouraged throughout the evaluation. And by the end, I even said, if you want some time to think about it, I again don't want to force therapy on you. I understand this is something your partner wants. I know you mentioned some things you're struggling with, but you don't seem too, you don't seem too thrilled about these services. And so I asked a lot of questions. What were the things you did with this prior speech therapist that you didn't like? And the patient and their partner told me it was naming tasks. Absolutely hated any sort of naming task, any sort of labeling, any sort of sentence completion. These were things that this patient felt were childlike for them,
Mhm.
but also something because of they also had expressive aphasia, they knew this information and obviously just couldn't get the word out. So continuing to ask and ask, they were just not about it. But being the speech therapist that I am, I did explain how this is something we could work on, using certain strategies and cueing, and just to make sure that this negative experience hadn't totally kind of, closed that door. I wanted to see if it was a little bit open. It was not, it was closed. So we moved on. I said, all right, we won't do any naming. That I promise you. I said, we will never do a naming sentence completion task in here. What are the things that you want to do though? I said, because based on here's the assessment, here's what your partner has told me you want to do. What do you want to do?
Mhm.
And so when I had the consult with the partner, they told me that they don't participate in hobbies anymore and they're very withdrawn socially. One thing that this couple was not aware of that I was able to provide some education on was that kind of social emotional component that comes with a cognitive communicative impairment, where the partner a lot of times just thought they were doing these things to be difficult
Yeah.
or to do it on purpose, or come on, why wouldn't you just pick up the phone, just call your friends already, and so I providing some of the education on the reason why these things weren't so easy, that initiation piece was different, and explaining how some of the mental issues that can happen or behaviors that this patient was struggling with were impacting her ability to complete her hobbies. So during our evaluation, I said, what are your hobbies? And come to find out, she loved emailing poems to family members. So
Oh,
they would often go to the library, rent a book, come back. She would find a poem, type it up, and then send it to members of their family. But in the course of their strokes, stop going to the library, stop typing, stop talking to family. And so what our therapy sessions worked on, I should say, sorry, I gave the Lawton scale, I gave the communication confidence rating scale for aphasia. And then I also gave, I didn't mention this one before, the Addenbrooke cognitive examination as well. So those were the 3 that I gave. And so through the results of those 3 assessments, on top of the patient caregiver report, we decided that our therapy sessions were going to focus on memory, visual attention, and executive functioning skills for email, going to the managing a library trip. We worked on scanning and attention for finding the poems in the book. We just worked on a lot of sequencing, problem solving, lots of visual aids, and those were really our sessions. And it was so much fun. This patient enjoyed it so much. The caregiver enjoyed it. The last time they sent an email prior to starting speech therapy with me was 6 months ago. So
Wow.
to be able to do something that they hadn't done in 6 months, I kept saying, like, that was also another thing, having a hard time monitoring progress and keeping track of that. So I always wanted to keep that at the forefront of their mind. This is something you weren't doing 6 months ago. Look at this. You're going to the library, you're typing out emails. I think from when we started, it took an hour to type an email, a very short email. And by the time we ended, we were about 20 minutes with cueing, with physical cues as well as some assistance. But when you think about someone who's 80 and who has had 3 strokes and has relatively no social contact other than their partner, and completely lost the skill to do the one activity that was keeping them social, like, that's huge. So you can imagine why they were so upset doing these naming tests. Get out of here with naming pictures. I don't need to do that, right? I want to read my poems. I want to go to the library and I want to start typing again. And so, yeah, it was really cool to see how their typing got better, less errors, to see them become more independent in navigating the computer, just teaching the both of them about accessibility features on the computer, which they didn't know about, right? I don't know how many 80-year-olds know about. You can change your cursor to a bright purple cursor, so you'll be able to find it on the screen a little bit better. So just things like that. And the care partner was so wonderful and very involved, sometimes much to the chagrin of their loved one. But it made for a really great time. I think it really changed this person's mind as well on what speech therapy could be. And at the end, I did end up discharging because I said, listen, when we started, this was your goal. We've met your goal. I said, but if you remember, these were some other things that our assessment showed you had some trouble with. You told me these were things that were not important to you to work on. Do you still feel that way? Or is there something else you'd like to work on? Because also, that's one thing. I'm not going to just keep coming here, right, to sit. We can't do that. Insurance won't pay for that. And you've met your goal. So either we're working on a new skill, or we've got to discharge. And so we ended up discharging, and the patient, said, no, this is all I want to do. I want to stick with this. And I was proud that they were able to make that decision for themselves as well. And it was a nice moment.
Yeah, no, I agree. And I think it's helpful because sometimes what these assessments and things like that show us don't reflect what the patient's wants are, and that is really important. Because I would sometimes use a naming task as a warm up, particularly for patients with aphasia, but sometimes that becomes awful, right? If they can't
Yes.
name 2 things,
Yeah.
like cat and bear, I'm just making something up, but you
Right.
get to, or baby, you get to the first 2 and they're like, it's taken 10 minutes and they can't do either one of them. What's the point? It makes
Right.
them feel anxious and upset, and they a lot of times know they can't get the word out, but they know the word, and it just becomes this barrier in therapy. So not only do they now not really trust you, and they're not having fun,
Yep.
And I've been to physical therapy before for my shoulder, and it was not fun. And, by the time I finished, I was better, but it was not fun. If it had been more fun, I might have been a little bit quicker to go and
Right.
stick with it.
Yes.
So we do have a question that says, I work in acute rehab and we have to report objective FIMS for Medicare and discharge. Yeah, I had to do that too. With these activities you're describing, how do you score these? And I think we could both probably provide some insight to that. So if you're looking at FIMS for communication, or like, I'm trying to remember what they all were because it's been a minute since I was in inpatient rehab and we used FIMS. The two things when it came to level of assistance were people that wore hearing aids or glasses. They would never be a 7. They always had to be a 6 because they're using an assistive device. We had someone who trained us on FIMS, and we did a FIM test every year to make sure that we were up to par on how we were scoring, and so that we could be more consistent as a department. And so when you're looking at the functional activities, so say you're talking about, like Alex was mentioning, typing, that's definitely a functional skill. It's communication. It's a form of written expression or a form of expression. So writing, typing,
Mm-hmm.
speaking. So you can use that and their level of assistance to score that. And I was trying to think of what the other one was, but I'm sorry, if you hear thunder, we're in the middle of a thunderstorm and it's really loud and kind of off-putting, but Alex, take it away.
I was going to say, I have not had acute rehab experience, but within the context of these, because I've had clinicians say, well, how is typing therapy, or how is sending an email or working on AOL therapy, right? But thinking of those, first, what is the functional task? And then what are your speech and language domains behind that, right? Are we working on, like you said, expressive language for typing, right? So they can send those emails. Are we working on attention, visual attention? Are we working on reading comprehension? So I don't know if that answered your question. I'm sure Renee answered it a little bit better than I did, because I'm sorry, I don't have acute rehab experience with the FIMS there. But please let us know, Melissa, if you needed more clarification there.
Yeah, for sure. Yeah, because thinking about comprehension, if you had hearing aid, it would be a 6. It would never be a 7 because they used a hearing aid. And if they didn't use a hearing aid and they were hearing impaired, they also could not be. A 7 is independent. You couldn't be a 7 and independent if you're hearing impaired, because even if you don't have a device, you're still not independent because you need some level of cueing, whether it's visual, written, or whatever.
Gotcha.
Yeah.
So I would say
in
the case of this specific patient, Melissa, this patient, I say, would have been not independent really in any area except the verbal expression. So everything else was impaired, and then just bringing those hobbies of the patients into those areas. So but thank you for clarifying. That was good info. Appreciate that.
Well, thank you so much, Alex, for joining us. I know this was a Monday night of fun. It was really fun, though. It really was. And I really appreciate
I enjoyed
the insight. When we did the spring conference together, I really enjoyed your presentation, because I found that a lot of the things that you were saying about establishing rapport and really being more mindful in how we treat our patients for functional things that they really need really was a match of what I've tried to do throughout my career. So I appreciate you sharing your expertise with that and your ideas for how we can be meeting those patients where they're at and giving them something that means something to them and is meaningful. So thank you so much for being with us.
For the opportunity. I appreciate it.
Of course. Again, Alex, thank you for being with us and sharing all of your knowledge, and well, not all your knowledge, but a good part of your knowledge. And feel free to come back and share some more knowledge. How about that?
Would love to. Thank you so much, Renee.
All right. Take care.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.